to introduce myself, Zori Talib. I'm an internal medicine physician and a professor of medical education based at California University of Science and Medicine. I have the privilege of co-chairing the Global Forum on Innovation in Health Professions Education with my co-chair, Pat DeLeon. And this forum is bringing the workshop to you today. So in my role as forum co-chair, I want to thank the co-chairs of the workshop, Dr. Donna Ferguson and Dr. Andrea Pfeiffer, for all their hard work in organizing what is going to be a fantastic meeting. I also want to thank all of our speakers, and special thanks to our guests and member sponsors of the Global Forum on Innovations in Health Professional Education. Without the member sponsor financial support, we could not bring you the workshops that I think are really moving the needle in our thinking about the needs and value of health professions education. To that end, if you enjoy the meeting, please consider becoming a member sponsor of the forum. If you are interested in learning more about how you could become a member sponsor, please contact Patricia Cup. Her email and name is on the slide in front of you. And with that, I will hand it over to our co-chairs to get us started.
Thank you. Welcome everyone who is here in person and to everyone who is on Zoom. I'm Andrea Pfeiffer. I am Associate Vice Chancellor for Professional Practice and Education at The Ohio State University, and here I represent the National Academies of Practice. I am joined by my co-chair, Donna Ferguson, who will introduce herself shortly. As a reminder to bring us into the present, we had a pre-workshop session in November on the 15th, where we explored ideas as to how we might build the healthcare workforce to better be prepared to care for the needs of older adults. There we used an implementation science lens to talk about how we could build the evidence base for service learning activities that could inspire health professions learners to want to work with older adults as a career path. One challenge that became clear during that pre-workshop was that geriatrics is not as a content area required by any of the professions, and in some cases, just getting schools to offer selective or elective opportunities for students to work within their professions, much less across professions focusing on older adults, can be a struggle. Those were great foundational discussions, and they are posted on the forum's website, so if you haven't taken a listen yet, please do so. Those discussions bring us into today's workshop, where we're going to aim to continue the conversation on how to inspire learners and health professionals to seek formal training and continue their development as they work with older adults from within their own profession, and again, across professions, so that we can really meet the full spectrum of service needs that exist. But when we talk about team-based care, we can't forget who the captain of the ship is. And so we're going to start off today with two of our captains of the ships. And that is the patient, the person, the client themselves. I'm going to hand the microphone over to my co-chair, Donna, now to introduce herself, and two of our team leaders joining us from the north via Zoom and from the south in person, and just really share my gratitude to both of you for being willing to share your stories with us.
Wonderful. Andrea, thank you so much. I'm Donna Ferguson, and I'm a program manager for mental health and wellness within the Department of Defense. And it's an honor to be here with you today as well. And as Andrea was speaking, we're talking about patients when it comes to healthcare and our health profession today. You know, patients are people that are at the center of our teams. And as a result of that, if we're going to have that type of discussion and the importance of the team approach to educating our learners, then we definitely want to be able to hear from those who are at the center. So to that particular end, I'm joined today again via Zoom with Miss Nancy Cruz and in person with Miss William Burrows. I call them my city mouse and my country mouse. So we get to see the wide spectrum of what's happening. And they're going to help us today to better understand and kind of set the frame for where we're going today. And so I've got a few questions for them, and I just believe we're going to grow and learn so much from them. And so I want to be able to start with you, Miss Nancy. Miss Nancy, could you please tell us a little bit about yourself, your background, where you live, and how do you get around?
Hi, everybody. I live in Queens. I worked in a hospital for X amount of years, 30, 35 years. In between, I did visiting nurse service, and then I transferred over to the Department of Education as a school nurse. which is very rewarding. Well, it was, I retired, but I loved every minute of it. And now what I do is I volunteer at my senior center, and I do blood pressures for the seniors. I listen to their problems because some of them are so lonely. All they want to do is talk, 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 talk. And I listen, listen, listen. And that's it for me.
And so, Miss Nancy, as you were talking, I was thinking about how do you get around? Can you tell us a little bit about that?
Well, if I'm going far, I'll Uber it. If I'm going close, I take the bus or I walk. I walk a lot because they recommend I walk a lot. So I do walk a lot, or I Uber, or I take the bus. Either way, I do get around a lot by myself.
Wonderful. And so also with that, do you rely on anyone else for assistance, or do you help others with assistance?
Well, I try to help these seniors at the senior center because a lot of them, they go there to have their lunch or something. And sometimes they just need help to open a little container of milk or to get the straw out, just little things that you do for them. They appreciate a lot.
Yeah, I appreciate that so much. And so I'm going to go to your country mouse and I'm going to ask Miss Willie Ann. Miss Willie Ann, can you tell us a little bit about you, your background as well, and how you get around?
Well, I get around, first of all, I live in Thomasville, Alabama, where I drive myself around to go to the doctor. And a lot of my doctor's appointments are in Mobile, Alabama. And then I visit my children and the grandchildren, which some in Birmingham, Mobile, Missouri, and so forth.
And you're telling me you drive to those places?
Yes.
And how old are you?
80.
Oh my, you and Miss Nancy. So do you rely on anyone for assistance, or do you help others with assistance?
No, I don't rely on anyone for my assistance, but I have two young ladies. One is 86 and one is 101. That the 86, I watch over her every day. I cook for her and I clean, take her to the doctor or wherever she, sometimes she just want to get out and ride around because she's not able to drive either. And the 101, I spends the night with her because her daughter works swing shift at a mill. So it's very rewarding.
Wow, wow. Miss Nancy, do you want to add to that?
Yes, a lot of them need someone to help them, even with little things, even just to talk to them. We don't realize how older people get very lonely. We really don't realize that part. They're very lonely, and just being there talking to them is such a big deal for them. That's my opinion.
So I think about the fact that, and I heard you say that you were a nurse and numerous years working in the health profession. And then I
Right.
hear Miss Willie Ann talk about the fact that she's taking care of someone. So one with formal education for caring and one that doesn't. And so when we think about this, I think it's important for our audience to think about this concept that we have those in an aging population that are taking care, some in the profession and some that are not, and what services are available to be able to assist. And so, Ms. Willie Ann, I heard you say that you actually take the young ladies that you take care of to their doctor's appointment. How does that work? How do you support them in that?
Well, one of them, the 86-year-old, she's not able to drive, so she uses a walker. So I carry her, make sure that I keep her medicine the way she's supposed to have it. And I have to listen to what the doctor say because she forgets, and she don't have anyone to talk to but me because all of her children live in different cities. And so it's challenging, like Nancy said, they get lonely. She gets so lonely, she does not want me to leave her. So I have to, I call her when I'm out of town, I call and I make sure that I get someone there to assist her while I'm away.
So when you're away, is that someone in the health profession, more friends, relatives? What does that look like?
It's my relatives that I do. No, it's no one in the health professional. It's my relatives. I call her to, check on her, see if she need anything or, whatever she need, is somebody there always to take care of her.
Wow. And so as we're looking at that and we're talking about the health science as a profession, there's a diversity of who we are. So I want to take a moment to talk about nutrition. And so, Miss Nancy,
Bueno, si
talk to me
tanta,
about-
tanta vis-
I'm sorry.
can you talk to me as it relates to nutrition for you and how you help those who are around you, that you support them? What does that look like as we talk about our aging population?
Well, when I help the ladies at the center, their food is already prepared. A lot of them don't like certain things. So you have to like coach them. Well, just try it, you might like it. And you just have to go with the flow with them, because as they get older, they don't want to lose their independence. So they want to eat what they want to eat, and they can't always have that. But we try to understand that once in a while, you gotta let them have a little treat of something that they're not supposed to have, even if the doctor doesn't like it.
I love it. So Miss William, what about you? What about your health? How do you do that as you age? And then talk to us a little bit about those young ladies that you take care of.
Well, for myself, I try to eat right. For my breakfast, I usually make a smoothie. And most of the time, when I make my smoothie, I always make sure I have fruit and vegetable. Now me, I use cabbage. I shred my cabbage, freeze it, and when I want to use it in my smoothie, I just get me a couple handfuls and put it in my smoothie and blend it in, and that's my breakfast with my fruit and my vegetables. And far as my young girls that I take care of, one of them does not like to eat. She have funny tastes and stuff, but I make sure I fix her what she likes to eat. And she likes to eat bacon and croissants. So I make sure I keep plenty of that for her. She has to have her Dr. Pepper. And for her snack, she wants, it's a little old bar. It's called whatchamacallit. She loves those, but you have to hide them so she can find them, because she will eat them all at once.
Now, is it the 101-year-old that likes to eat the croissants?
No, it's
and
the
bacon?
86.
I just want to know.
86. The 86-year-old likes to eat the bacon and croissant.
Wow. So what about the both of you with your physical health? How do you take care of your physical health, Miss Nancy?
Well, I walk a lot. I don't depend on anyone driving me anywhere. I like to walk. I walk to the supermarket. We have a big avenue where they have a lot of little stores. I take a walk to the 99-cent store. Walking is my thing.
Yeah. And so Miss William, what do you do?
Well, for me, since I work every day, I go to the gym 3 days a week and work out.
Wonderful. I absolutely love it. And I heard you say that because you live in a small town, Thomasville,
Yeah.
that if you are not seeing your primary care physician, if you have to go and see a specialist, that you have to travel to Mobile, Alabama. Is that what I heard you say?
Right.
How far is that?
It's about 100 and some miles.
So you don't have the conveniences of the services that you need.
No,
Okay, and so those young ladies, that means if they have specialists, then you got to take them 100+ miles wherever that
Right.
is as well.
right.
Wow, and so, but Nancy, for you, how does that work?
Well, it's easier for us. We have more transportation available. There's always a bus like in every 2, 3 blocks. So it's easier for us to get to where we're going to get our health care. A lot
Okay.
easier.
Yeah. So what has been your experience though as a patient with the healthcare system and your doctors or your specialists? What has that been like for you?
Well, for me, I haven't had any problems. My cardiologist and my primary care, they seem to tune in together. They speak to each other after I visit. They talk to each other about the findings and my lab results. They keep in touch with each other about my healthcare. I've been lucky that way.
Yeah. So Miss William, what about you? How does that work for you in a small town, in a small community?
Well, my doctor, Dr. Davita Dozier, she's my primary doctor. And I have a heart doctor and so like Nancy say, they communicate even with the specialists. They have to get all that information from your primary doctor. So it's easier for me, that part is.
Yeah. And what about being able to translate for the both of you and communicate as the doctors are talking, the language is, of the profession? How does that work?
Oh, for me, being a nurse for so many years, I can understand their lingo, but I'm sure a lot of people can't. And they tend to be a little bit abrupt.
Miss Nancy, can you tell us a little bit more about that?
Sometimes from the seniors at the center, I have heard that they're talking to their doctor about something that they need, and the doctor has one foot out the door. So it just depends on the personality. And I always try to tell them, you can speak up, you can say, hey, whoa, where you going? I'm not finished yet. And they do come back and listen.
Miss William, what about you?
Well, with Dr. Davita, she takes time to explain things to you and she will sit there and talk all day if you don't tell her you got to go. But I love her for that because it makes me think she's concerned about my health.
That's important. That is, so your specialists are like that too?
Yes, Dr. Ferguson, he's my specialist for, in other words, maybe 6 months ago, I was having a problem with my feet and leg and didn't realize that my blood was not circulating good. So I had to have 2 stents put in.
Mhm.
And with that, I don't have no pain and all, but he always makes sure he explain. And if he sees something that he don't think is right, he gonna go back and do more x-rays and all, make sure everything is okay.
Yeah. So then as we talk about and have this conversation for the both of you, and Ms. Nancy, I want to start with you. Is there anything with the healthcare system that concerns you or areas that you feel need improvement?
Well, I think yesterday I did say that the young girls that are coming just now, I don't think they have the time that we older nurse had when we were doing patients. If I had 6 or 5 patients, they have 10 and 15. They're going to miss certain things that are not supposed to be missed, but they can't help it. They need a lot of support. They really, really do, from the older nurses that are working on the unit, because they are overwhelmed. They really are. Healthcare is overwhelming and it's very hard for them. And we're losing so many young and good nurses that could really, really do so much good because they're not given the support and the time that they need. My opinion.
And Miss William, what about you? Is there something that you would want us to know as a health science profession or areas you think we need improvement in?
Well, I would really like for my small town that most specialists would move in, where older people's older than me wouldn't have to drive so far, depend on somebody else to take them, to the doctor and all.
Wonderful. Well, I just want to say thank you both for affording us an opportunity to be able to have a conversation with you and for you to provide insight to us. We appreciate it so much. And I'm going to turn it back over to Andrea.
Thank you. Thank you so much, Nancy and Willie Ann and Donna, for sharing part of your stories with us. And now we're going to build upon what you just shared with us to dive a little bit deeper to see if we can uncover what matters most in terms of how we prepare the future workforce and our current workforce to do the job that you have every reason to expect us to do. So to walk us through the discussion, I'm going to ask Katrin Lynch to turn on your camera. Dr. Lynch is the Dean of Faculty and Professor of Anthropology at Olin College of Engineering, where she teaches courses in anthropology, design, engineering, and entrepreneurship. She strives to expose engineering students to critical analysis and identification of the needs and opportunities in our aging world. To see her full bio, please go to the biography section of the agenda packet. And with that, I ask Katrin to please unmute. The floor is yours.
Hi, everyone. Thank you very much. This is great to see people, and I see that some people are in the room. So thank you very much to Patricia Cup for inviting me and Hannah Goodtree. Both Patricia and Hannah were helping me with the logistics here. I have a presentation that I'm going to give, and I'm joined by three other people who are also on Zoom. We have, first I'll share my screen and then I'll explain to you who we have. Okay, just a minute. Do you see my slides that say what matter most?
Yes.
Someone confirm that. Thank you. And do you see only the slides, not anything else?
Yes, we do. You're all set.
Okay, perfect. I don't want to be showing things I shouldn't be showing. Okay, so I have made that mistake before. I am joined today by two students from Olin College of Engineering who are Ian Eikamp and Zoe Leo, as well as one person who participated in a class that Ian and Zoe were students in. So Peg Whitall is also here. She's a local older adult who lives in our community. So what I'm going to do is to talk about a class I teach called Engineering for Humanity. And so I'm going to give a presentation with it where I tell you a bit about the class. I'll show you, let me see if I can get my slides to advance. I'll tell you about this intergenerational course. I'll tell you about Peg is here and Zoe and Ian were on her team. So Team Peg's experience. First, we'll hear from Zoe and Ian, and then we'll hear from Peg. And then I'll just have some wrap-up comments about why this matters. And we should have time for some discussion. So that's my plan. First, I want to tell you about, we use a design tool in the class called the Innovator's Compass, which was created by my colleague Ella Ben-Ur, who I have taught this class with many times. And so at the center of Ella's compass, which I'll show you in a minute, is people. Like you need to, in order to make a difference in the world and in the world of people you're working with as medical practitioners, as professors, as engineers, you really need to put people at the center of what you're trying to do. And so I'll tell you about the people, the professors in the class, then you're going to hear from the students as well as Peg. At the end of this, I can put in the Zoom chat a number of resources, and I don't know how the people in the room will get those resources, but I'm sure we can work on that. So in terms of the instructors for the class, so my name is Katrin Lynch. Thank you for the introduction. I'm the Dean of Faculty at an engineering school, Olin College of Engineering in Massachusetts. I'm also a cultural anthropologist. I have a bachelor's degree from Bates College. My master's and PhD degrees are from University of Chicago. And I have done research. My research focuses on manufacturing on the global apparel industry. I'm writing a book right now about a textile mill in Massachusetts. I've written a book about garment factories in Sri Lanka, a needle factory in Massachusetts. And the needle factory in Massachusetts got me thinking about aging, because this is a place, it's actually, my story is not as complete as one might hope. It's not a knitting or sewing needles, it's medical needles for like, giving injections and things. But the workplace, which is called Vita Needle Company in Massachusetts, the median age of the employees is 75. This man was 90 when I took his picture. He's now 102. He only recently stopped working. So I was doing my research about aging, I mean, about manufacturing, and I ended up getting interested in aging. And now it's been many years since I've been focusing on cultural experiences of aging. I had to learn about aging as an anthropologist. I took I was on a National Institute on Aging Summer Institute on Aging Research. I also did a RAND Summer Institute, which was called a mini medical school for social scientists. And also they had a thing called the Demography, Economics, and Epidemiology of Aging. So through some formal and informal things, I learned about aging, but not in the same way that medical practitioners like you all have. So I've done various kinds of things on aging, but for me, the most meaningful has been teaching this course that I've taught maybe around 10 times where, and I'll tell you more about that. I'm just gonna skip some of this. I have a TEDx talk where you can hear a little bit about what I do with students. Ella is who I teach with. Ella is somebody she's an engineer and designer, came from MIT, where as a graduate student, she was designing, this was something to train surgeons. I don't know exactly what it is, but she was designing medical equipment. She ended up working for a long time at the design firm IDEO, and she and I have really hit it off working together and working around what Ella has created called the compass, where you think about people, you're trying to innovate. And so even for like, if you're trying to understand people you're working with, even as doctors and nurses and all sorts of medical practitioners, first you want to understand what's happening, what really matters to people, and then come up with some ways to create change, holding on to what really matters to people, the principles. You don't want to innovate things that have no relevance to the people you're working with. And then you want to try out some things, see what you learn from it, and try the process all over again. So that's what this compass is, and that's how our class is oriented. And you'll see a little bit of this in practice. So the class, Engineering for Humanity, you can find the entire curriculum and samples of student work and lectures and things on a website that Olin has here. I can provide this link to the people on Zoom later. But I'll tell you a little bit about it. It's a class that it's very interdisciplinary. The students get half the credit in engineering and half in anthropology. At Olin, it's specifically the arts, humanities, and social sciences, but it's half anthropology, half engineering. The students are from Olin College as well as Wellesley and Babson colleges, which we're in a consortium with. We partner with the students with older adult community partners. There's instructors involved, and we partner with a local council on aging, and that's really it's a relationship we've built over many years, and we couldn't do it without the council on aging. Typically, I created the class originally with another professor named Lynn Stein, and I taught it with her a couple times, then with Ella many times. And the year that Team PEG was in it, we also taught it with a local high school teacher, Hans Batra, who ended up bringing some of this into his high school intro to engineering class afterwards, which was really wonderful. So in the class, we recruit senior citizens. Oh, sorry, I actually try not to use the word senior citizens. We recruit older adults into the class to participate, and we do a whole recruitment process trying to find. When I first created class with my colleague Lynn, we wrote a grant. We got a grant from a local healthcare foundation, and we made an argument about aging in place and the importance of aging in place, and that we wanted our engineering students to work with people who lived independently and who the students could connect with, find out what they were trying to do, like what was important to them in life, and maybe the students could design and build and hand off something to help people achieve their goals and be able to stay in their homes. And we know there's lots of positive health outcomes related to aging in place and staying in one's home. So the students at first get to know the older adults who are participating in the class. Then they'll end up through a process. So here they're in this process here, they're getting to know the person, what matters to them, coming up with some ideas on things they might do to help people achieve their goals, trying out some things, and they keep doing this process. And they end up like focusing on working with a particular person, or, in some case, a married couple, and try to immerse themselves into their lives. Here was a team working with a woman named Terry, and they went grocery shopping with her. Our students go, to movies with people. They'll go play chair volleyball in a senior center, all sorts of things. This is pre-COVID. You will find out soon that Team PEG entirely interacted with PEG over Zoom. Except for a couple of exceptions, which you'll also see. So in this case, like this Team Terry, that like a really obvious thing that a team of engineers could do is go grocery shopping with somebody and literally come up with an idea of she could use some help getting things off the shelf. So like in Terry's case, they went through the process and they stopped at principles and they said, what matters most to Terry? Independence, social engagement, and she's a very positive person. So holding those things in mind, they then went through they had some ideas like grocery shelf reach was an idea, oven door access. They went and spent time with her in her home. Multimodal alarms because she could both hear and get a vibration for doorbells and things like that because of hearing loss. And they ended up focusing on the grocery store experience. They did a lot of playing and prototype and producing prototypes and ideas in the space of carrying groceries. Terry uses a wheelchair. She is able to use the public transportation for older adults where wheelchairs can be put in and out of a van. And at first they thought, and here you can see in the classroom, they were saying like, how could we stack Terry normally puts her 2 bags of groceries on her lap when she goes to and from the grocery store. And they thought, well, let's put 4 bags on the back of a wheelchair because that'll be convenient. But because they had the principle of social engagement in mind, they realized that for Terry, going to the grocery store was really important. So being efficient. So some engineers might accidentally prioritize efficiency. So if they knew that a principle for Terry was efficiency, then that might have been appropriate, but they knew that what was most important to Terry was social engagement. So they got around to 2 bags. So what if we put 2 bags on? So they had a prototype. Terry went to the grocery store. The students went with her. They went into her home and saw her unload her groceries. And they came up, this was the final project, which they gave to Terry. It's purple because that was her favorite color. It has communication symbols for the people loading the groceries. And mostly for Terry, it was a point of conversation. So she would go to the grocery store with this rack and be able to meet even more people. And that's what really mattered to her. It wasn't about acquiring groceries. It was about talking to people. And this tool helped her with that. So I can tell you about more projects. I'm going to show you a couple more because I think they're really exciting. Some of you might be involved in occupational therapy, but some of the projects might resonate. But I'm often conflicted, because I don't want to overemphasize the things. When we wrote the grant proposal many years ago and got a lot of money to support this class, we really emphasized the things the students would make that would help people age in place. But the class is really not so much about the things. It's about the relationships among the students and the older adults they work with. And you'll hear some of that from the team. It's also at the same time, engineers are learning, they're really honing their engineering skills. You'll see that when Ian and Zoe show you what they did their first year as engineering students at Olin. They're now in their 3rd year, I think. Zoe and Ian, I think that's true. Actually, I know that's true. And so you'll see that they're developing their engineering skills, and engineering skills include people skills, as would be the case for people in medical school training, right? And so really understanding the experiences of older adults is important, but these projects are cool too. So I'll tell you about this. They worked with a team, a husband and wife, and the husband had a neuropathy in his feet related to having diabetes. And so we know that sleep problems among older adults are a huge problem. And so this man would wake up his wife in the middle of the night to massage his feet. He was in a lot of pain. He needed to do that. So then neither of them are getting sleep. That's a huge problem. So the students designed something here where he could wake up and massage his own feet. And they used this, and this was huge. It had a transformative impact on both of their lives. In this case, it was very simple. These are pebbles that you might put in a fish tank, and they attached it to a box. And so it was, simple, but really impactful. Here is a woman with macular degeneration, and going through the exercise of what matters most to her, it was telling stories about things. And they built a simple sort of device so she could take photos, put them in a box that would project things in a resolution that she could see more than she could if it was just the photo in her hand. And then she could tell people who visited about these pictures. So that's building from what really mattered most to her. This one is the team worked with a woman for whom cooking was most important. And she couldn't cook anymore because she has macular degeneration and glaucoma. And maybe if any of you are ophthalmologists, you would know this better, but she has some kind of vision condition where if she had a lemon and went to grab the knife, she wouldn't be able to find the lemon again. And so they worked with her and made these, like, these were prototypes in front of her. The final product is in the bottom left. They then they made a cutting board and they worked on like what kind of material, and the stripes actually helped to direct her vision. And the thing in the bottom right of the final product, her husband, who is a machine, like used to run the machine shop at Wellesley College, came up with where you could take a stick of butter and she could cut tablespoons without seeing them. And this is like, it seems sort of quaint, but it's hugely important. Baking and cooking and really important to her. And she could do some of this without having to ask her husband. And not all the projects are about gadgets. This is a team worked with a Chinese immigrant community who had medical appointments, and they made some laminated cards with translation. Red was for like in the hospital and blue was for on the way to, I can't remember what green was. This is a great project, but I'm going to skip some. So I'm going to skip so we can hear from the students and Team PEG. So I think I'll do that. Zoe and Leo, Zoe and Ian. Zoe's last name is Leo. So we have Zoe, Leo, and Ian Einkamp. I'm not sure who's speaking first, but I can forward the slides if you all want to start talking.
Okay, yeah, next slide. So I'm Ian, and my community partner was Peg, who is also here. And this project ran in the spring of 2021. And so this photo that you're seeing was actually taken like at the very end of the semester, because that was spring 2021 was right when the first COVID vaccines were starting to become actually available. So for the entire duration of this project before that, we had to do all of our interactions with PEG. They were all completely online. Next slide. So when we're designing for our community partner, it's important to get to know them pretty well. And that doesn't just mean like their routines. It means also getting to know them as a person. Like we asked for photos of Peg's family, of her dog, because these things, it's hard to know what exactly is going to be useful without kind of getting to know all aspects of the person who you're designing for and their life. So next slide. We did settle into, Peg had this idea of something that was in her routine, which is going up and down the stairs carrying a load of laundry. So she kind of, this is again all over Zoom. She was trying to like describe this problem to us. And was like showing us pictures of what her staircase looked like what the diameter of the railing was. Got someone to take a video of her going up and down her stairs with her laundry basket. And we had these Zoom sessions where she would we kind of exchange ideas. And so you can see photos of her kind of demonstrating with like kind of a box of just like kind of found materials to try and like show what ideas that she had. And I think having this way to share ideas was really important, because we could take those ideas and we knew that whatever Peg could come up with on her own would be so much more relevant to the actual situation than anything that we as engineers could like come up with just by kind of thinking in our minds, because we had not seen what it was like for Peg. We'd not even seen her staircase. So next slide. So it's really important to kind of get Peg's kind of firsthand perspective. And so this is just a photo. The stairs are actually a lot steeper than they look. And so it's just showing that kind of like how kind of precarious it is to carry the laundry basket down the stairs. And that's that was a solution that we were trying to come up with, how to get the laundry basket down the stairs safely. Next slide.
So for this class, we used a lot of the values from the compass that was mentioned earlier. So like during and after discussing with Peg, we as a team generated ideas, and we tried to like not limit ourselves in some of these brainstorms, which is why you see a very creative idea of Peg throwing a laundry basket into a basketball. All right, next slide, please. So from the ideas that our team came across and that we got from discussing with Peg and that Peg suggested, we did some experiments where we tried concepts in sketch models, as you can see Ian demonstrating on the stairs and in the classroom, just trying to get the motions of what the possible designs would be like to see if the person interacting with the device is going to have a hard time using it. All right. Next slide, please. So some even deeper experimentation once our team and Peg settled on a design that we thought would be ideal. We did some iterative prototyping. So you can see at the, oh boy, I don't know which left or right it is for you all, but the small gray one is our first, and then it goes along like an S to the larger black, white, and red one being the more like the closer to the final, or if not the final version. And along the way, we had design reviews, we got feedback from the teaching team, we considered safety of our materials and our prototypes. We also showed Peg all of the designs and we got a lot of feedback. And that was one of the key factors to what was driving our experiments. And if you could go to the next slide. So during our experimentation phase, we did finally get a chance to meet in person with Peg. And these are the photos from the results, but before the final time, we did meet with her and have her test some of the devices. And here is our like most recent version of the device that she has. And yeah, thank you for listening to our process.
All right, and Zoe, I actually have a video here, so I'm going to show the video.
Perfect.
All right.
It should be. We can also reinforce it.
All right, you want to get on the way for all these photographers? There's not very much weight in this, however.
Yeah.
Hook it on. And flip the switch. And it hurries down the stairs.
Perfect.
Excellent.
With that video, there's one more thing I want to point out.
Yes.
See at the end of the stairs, we have that like brown stopper.
Yeah.
That was something that was like essential to the design that we wouldn't have been able to find out without working in the like space that we were designing for.
Right, that's great. All right. Thank you, Zoe and Ian. Now, Peg, we would love to hear from you, Peg. And you know what I'm going to do? I'm going to stop sharing for a minute. So Peg, it's all yours. You have to unmute. You're still muted.
Okay. Thank you all. I'm Peg and I'm a senior, I'm an elder, I'm a community partner, which I liked better than any of the other terms. Olin was not in my sights. I have to give you a little background about how things occurred so you understand where I'm coming from. I retired early. I was 62. I'd worked full-time. I said, I can't work full-time anymore. I was working at 6:30 in the morning in a doctor's office and the pressure was getting to me. But I was very, very active in my retirement. I worked part-time jobs. I volunteered food pantry. I volunteered for 5 years as a nursing home ombudsman here in Massachusetts, visiting 2 nursing homes a week. I volunteered with the town doing flu clinics and various assignments. And I loved my life. I was able to travel. My husband and I were able to go west to the national parks until about 2014, when my husband started showing signs of Alzheimer's. And then as time went on from 2014 to 2019 and 20, his problems grew worse and my freedom to do things grew less. I became, by 2020, a full-time caretaker for him. He was in social day programs, which were a godsend. I found really good ones, but it took a lot of research. I was in, he was going to doctors 2 and 3 times a week because in addition to his Alzheimer's, he developed Parkinson's. And it became a very difficult time for us. So I had to finally give up my care of him, and I placed him first in assisted living and into a nursing home in late 2019. Well, 2019. Dates are not that important in terms of things. In 2020, we started with COVID. And unfortunately, he passed away of COVID in the nursing home in April of 2020, which left me in isolation at home with no caregiving responsibilities, no volunteer responsibilities, and really shut down from my life. My dog didn't learn to talk English as much as I talked to her. And my friends would call and check every day. And if I didn't want to go out, they would run errands for me if they were out. But we were all very careful. We were seniors, adults, elders, old people, whatever you want to call us. And we were being super careful. Well, by January of 2021, I was really desperate because my mind works constantly and I get bored easily. So I started looking for something I could do online or otherwise. And I got my mailing from the senior center, and they mentioned the program at Olin. So I talked to the people at the senior center, applied and was accepted and became a community partner. And I finally had somebody new, somebody young, somebody with ideas that I hadn't heard before and experiences I hadn't heard all my life to talk to and to learn from. So I was very happy about that. The class, well, it was COVID. And it was unlike any college class I'd taken, and I've taken a lot of college classes. I have a master's plus about 20 hours beyond it. And I've taken workshops, but this was like nothing else. First thing that happened with the class is I got a brown box at the door. And the brown box, when I opened it, had really strange stuff. No books, very few instructions, paper towel roll, a bunch of pipe cleaners, some clay, a couple pieces of fabric, and being old in college, a whole bunch of Post-it notes. And I'm sitting here, okay, what are we going to do with this? And then I had the first online class in a Zoom session such as this. And Caitlin and the other instructors said, okay, we're going to have you meet all the students in the class. And I suddenly felt like we was in speed dating, which I'd never done. I'm sitting with 5 people in my breakout room. We have 10 minutes. We're supposed to get to know each other. And you just about get yourself introduced. And the 5 minutes is up and you're with 5 other people and you're starting again. But they want to get to know you and what you're seeing as a senior and as a person who wants to stay in their home, which I have lived in now for nearly 50 years. And moving out would be harder than staying here for sure. So from these 5-minute sessions, we had people decide to sign up and have a longer session in smaller groups to get to know us. And after that, the teams were formed and Team PEG occurred. And I was really interested in the people on my team. They were new to me. They were something that could tickle my fancy. We had things in common. Andrew was a senior. He wanted to go on and did go on to study architecture. He liked sailing. He liked cooking. He liked traveling, all things that I was interested in and concerned with. Melissa was a junior. She had a dog and I had a dog and we talked dogs. And she also liked my attitude about continuing education after you're graduating from college. Nina was from Babson and was studying business, and I had run my own business for several years, so we had that in common. And then Zoe and Ian, who were here today, were freshmen in college, but they both liked the outdoors, and I think they decided to be on my team because I told them I had hiked the Grand Canyon and I'd been outdoors and done a lot of things. So we had common interests, and that was a starting point. I think some of them had relatives with Alzheimer's, and I had mentioned that, and I think they felt a connection there. We met several times, we talked, they defined several problems I'd like to solve, but my real concern was my safety. I'm living alone in a house built in 1950, the stairs are steep. It's a slab, so my washer happens to be upstairs, and I have the opposite problem most people. I can manage going upstairs. I just put a basket on a step ahead of me, get me up a step and go. But coming downstairs, the weight of the basket made me unbalanced. So we were back and forth about a lot of ideas. I nixed the basketball hoop pretty immediately. I told them I had a lamp and a door with a glass window at the bottom of the stairs. If I missed, we may have problems. I nixed some of the other ideas because they hadn't been in my home to see things. They didn't realize that one of the stair rails only went up half the stair and then it was solid wall, and you couldn't run something on two stair rails. And so it went, but we came up, I feel very responsible. I came up with the idea of writing something down on one rail, and we called it the stair rail writer, and that's what we developed. And the students, the young adults showed you what it looked like and how well it worked. And I'm not going to get into that process beyond saying we had to develop a lot of trust. I was somebody out in the boondocks, and they were in 5 different places because they all lived in different places because of COVID. They couldn't get together. I watched their team develop, and I watched them learn who would take which responsibilities, which was important. And to form a team, you can't just pick people and put them together. You really need people with different abilities and responsibilities, and they each found their own niche and created it. And I thought that was important. And when you start with somebody who knows nothing about what they're doing, except they're meeting somebody and doing something for them, they all found a way to communicate with me, I with them, and it worked really well. I was always afraid though, because I was communicating by Zoom, by text, by email. I wasn't communicating in person. I didn't know it. I had to laugh at myself one time. I have an email I sent. They gave me an idea and I really didn't like it. And I really didn't want to say, sorry, Ian, you're going to love this. I didn't want to say, that idea is absolutely crazy and makes no sense at all. So I read it and I said, I don't think that'll work. And I gave him an explanation. Well, then I sat down a few hours later and I said, okay, I'm going to send another email because maybe I didn't make myself clear enough, because I didn't say, I don't like the idea. I tried to be nice. I don't think I said this very clearly. So I'm trying to make it clearer. I do not think attaching the slider to the container is a reasonable idea. Right now, I can stand it, meaning the slider, against the wall at the top of the landing, grab it when I need it and mount it, easily drop the basket on and set it on its journey. At the bottom, I can store it against the wall and carry it up to the top with the basket of clothes. It stays where it's needed and does not make the basket heavier, top or side heavy, or just more cumbersome. Sorry, I guess I really just don't like the idea. We weren't in person. You couldn't demonstrate this. You thought it and you had to get the idea across. So there was a lot of communication, and I try and be gentle. I try and make my points without striving. I did learn also from the students to use Google Slides, which was a good thing. I had always taught myself things. They showed me pictures of their lives. I did that, and so on. But in summary, what I really feel the takeaways from this, theory is fine, but reality, hands-on, and practice is where the solution is. In theory, the package my last employer, who was a chiropractor, brought for medical billing was wonderful, but it was done by an accountant. They didn't understand anything about medical insurance. And to make it work, you had to really work hard. If they had talked to the person in the practice and built it from that end, it would have been much more successful. A second takeaway, you need seniors to be able and happy and comfortable communicating by computer. In the previous presentation, people were talking about their doctors. In this area, our doctors communicate often by computer. You have to be computer literate. You have to be on Patient Gateway, Patient Site, Patient something else. I'm on 4 different ones because I'm 4 different hospitals. You have to be able to figure this whole thing out. And then half the time the doctor sends you a message that's 2 words when you've written them 4 paragraphs. And that isn't communication to me. We as a team, Team PEG, developed good communication. We could talk to each other. They could send me a 2-sentence question. I'd send them 1-sentence answer. We'd be done. But we were on time, on point, and we kept current. And I think that is so important in any end, whether it's a doctor speaking to a patient, a teacher speaking to a student, or an engineer planning a project or doing a project with someone.
Peg, I might cut you off soon.
I'm sorry.
We need to finish.
Can I just, okay, just
Okay,
my
one more
one thing. Zoe and Ian are still in touch with me. We communicate. I've been to Babson College and seen things, but I just want to read this one little piece. It was my summary at the end of the project, given on Zoom. My thanks to Olin, the Engineering for Humanity faculty, the students, and Team PEG. I had been in a rough place with COVID and the loss of my husband and needed something new and interesting to invest in and concentrate on. This was it. The pleasure of working with young, ambitious, caring students, a faculty and facility which so strongly believes in hands-on learning and fostering community relationships, and all of the E4H program has renewed my soul and re-engaged my brain. So thank you, E4H. Thank you for your kind attention.
Thank you very much, Peg. I've done something like this with Peg before, and I think Peg speaks better than anybody else around. So we don't really have time for discussion, which I feel bad about. I do just want to say that, like, this is a story about engineering students, but it really can be a story about anybody. In my TEDx talk, I talk about, like, this kind of creativity isn't confined to professional anthropologists or engineers or designers. Like, we all can listen, and just like watch what's going on, do good observation, try to get beyond the obvious to really understand what really matters to people. And obviously the students understood that sure, Peg wanted to get her laundry up and down the stairs without hurting herself, but Peg also wanted social interaction, and Ian and Zoe are beautiful young people who knew that. And, Peg talks about the communication, but it went all ways. I mean, there were, students who really wanted to engage with her. So I'm sure other people can do this too. I'm super proud of Team Peg and really grateful to these students and also Peg. So thank you. I think we need to end. So,
Thank you.
a little about
We do, but story. Thank you so much, Catherine, Peg, and the students. Hopefully we'll have a chance to circle back to some of the key ideas that were shared. It was just a beautiful story.
That's great. Thank you. I'm going to throw in the chat a few resources if I can, if it lets me, but I can follow up with Patricia maybe and share them another way too. All right, so we're going to leave. Goodbye, everybody. Have fun. Have a good day. Thanks.
Bye.
Bye.
So as we continue building messages, we're now going to look more broadly at how different cultures view aging. And Dr. Kathy Maxwell from the Vanderbilt University School of Nursing will be our session moderator. Dr. Maxwell has a strong interest in interventions that empower older adults to engage in behaviors that enhance well-being and improve quality of life, just like what we just heard about. With that focus, I can't think of a better person to moderate this next session aimed at understanding the importance of a person's social, community, and developmental factors impacting health and well-being of older adults. So Kathy, if you don't have your camera on, please turn it on and unmute. The floor is all yours. Thank you so much for doing this.
Thank you, Andrea. So I am delighted to moderate this next session. Continue talking about working with older adults. We've got a wonderful opening speaker and a group of people on our roundtable that I think you're going to really enjoy. So let's get started right away. So our opening speaker is Dr. Ricardo Custodio. He is a professor at the University of Hawaii. He's coming to us from Hawaii and a physician at Kalihi Palama Health Center. And he's going to give us some opening remarks that I think you are going to just love to hear about. And Dr. Rick, I'm going to turn it over to you.
If I could have the slides, please. Okay. Aloha, and welcome to Working with Older Adults, Treatment, Care, Prevention, and Health Promotion. Mahalo for inviting me. I'm Dr. Rick, and as you can see, I wore white coats at an early age. I'm speaking to you from Kaneohe, Hawaii, and the Ko'olau Mountains behind me there are basically my backyard. My family is originally from the Philippines. Dad was one of the first Filipinos to enlist in the US Navy in World War II. That is why I was born on this tiny island. From the beginning, island culture and peoples have always been a large part of my life. And from the beginning, it has not been easy. The name of this island is Kwajalein, and it's part of the Marshall Islands in Micronesia. The entire island is a military base and was part of Operation Crossroads. Fun fact, do you know what personal history I and many Pacific Islanders have in common with these characters? In the 1940s, the Navy moved many peaceful Marshallese from their homes, promising to bring them back. Then they used hydrogen bombs to blow them up. You can kind of see how close Kwajalein is to the other islands. I was born in 1957. And the last atomic bomb was exploded in 1958. I remember Dad telling stories about Filipino sailors catching fish and getting sick after eating them. The Marshallese got sick after eating coconuts. The radiation contaminated the ocean and the land. Like those characters, I, my family, and my fellow Marshallese were irradiated. You may be wondering why a pediatrician is talking to you about working with older adults. That's because I see things through a developmental lens. And I wanted to give you an observation that I've been trying to understand for decades. But before I get to that, I want to tell you about another group of islands, the Hawaiian Islands. Hawaii is a special place. It is the most isolated island chain in the Pacific and the entire world. Going east, California is 2,400 miles away. Going west, Japan is 3,900 miles off. This isolation created a dynamic interdependency between the land and the people. In terms of the land and environment, it created one of the most biodiverse ecosystems in the world. And in terms of human habitation, it also created one of the most diverse multi-ethnic and multicultural states in the US. Here are some of my colleagues, friends, faculty, and students. Over hundreds of years, all this diversity and difference, certain island values became key to surviving, getting along, and thriving. In Hawaii, these values are malama, aloha, malama, and ohana. Aloha is love, malama is caring, and ohana is family. In Hawaii, these are expressed when you give the gift of lei. And I think you can advance a little bit. There you go. Right. And one more. There you go. Flower lei is given to celebrate special occasions, birthdays, graduations, weddings, anniversaries, goodbyes in person, and in remembrance. And I'm sorry, you can hear my chickens in the background there. We even honor the custom every May 1st, where May Day is Lei Day in Hawaii. I believe the world would be a better place if everyone, once in their life, experienced the feeling of fresh, beautiful smelling flower lei all the way up to your neck. We also celebrate our elderly and have a special name for them. In Hawaiian, it is kupuna. This is Auntie Aggie. She is a native Hawaiian traditional healer, a kahuna pale keiki, which means that she is a midwife. She taught me a lot about the value of family and community and the importance of respecting your elders. In Hawaii, you're officially elderly when a cashier calls you auntie or uncle and automatically gives you the 10% discount. That is a sign of respect. Our merging of Asian and Pacific Island cultures means we malama our kupuna, we take care of and respect our elders because that's what ohana does. In addition to being multi-ethnic and multicultural, many homes in Hawaii are multi-generational and crowded. This is not a bad thing. To quote Disney's Lilo and Stitch, ohana means family. Family means nobody gets left behind or forgotten. There is something to this. There is something about respecting and caring for the land and for each other. There is something about measuring wealth by being around nature, the beach, and the company of friends and family. Why are the words kupuna, malama, aloha, and ohana so important? Well, in a quantitative sense, this August, the CDC announced that Hawaii has the longest longevity out of all 50 states. And in a qualitative sense, this September, Wallet Hub released the 2022 list of happiest states in America, and Hawaii ranked #1. We must be doing something differently and right to live longer and be happier. Our priority is to care for our elders at home with the support of family and community. This is how I and many islanders were raised. It is expected that kupunas stay with their families. But there's another side, a darker side. And this is the observation that has bothered me for decades. When I was a fourth-year medical student in the ER, we had an elderly woman come in 2 to 3 times a week just to talk story. She was the mother of a very rich and well-known developer. She was resigned to the fact that her son and grandchildren never came to visit. All the money in the world and a big, beautiful oceanfront house in Diamond Head could not prevent her from being alone and lonely. Her family had left her behind and forgotten her. I've spent my career trying to serve those that have been left behind. My professional life has been about providing healthcare and access to healthcare careers for underserved children and students. I've worked in community health centers for over 40 years. My patients are the poor, Pacific Islanders, and recently arrived non-English speaking immigrants. We see them regardless of ability to pay. We provide comprehensive services beyond traditional primary care to include community health workers, homeless outreach, insurance eligibility, transportation, and translation. More importantly, we provide clerkships and training for health profession students to help them understand and experience what it is like to work in a community. The hope is to brainwash them into staying and committing to serve. Over the last 12 years, I've helped to start a medical school, a nurse practitioner residency program, a clinical psychology fellowship, and most recently, a university division of math, natural, and health science. all in poor and underserved communities. I got interested in STEM and health science when I found out that there are close to 100 distinct careers, and many are in the fastest growing occupations in the country. I've been focusing on training a smaller number of graduate level health professionals, and I saw this as a great way to get more underserved kids in Hawaii into health professions that can pay a living wage. Now, a few weeks ago, I had a medical emergency that showed me the power of community, love, caring, and family. I was recently hospitalized because I started peeing blood. Gotta tell you, it is alarming when you see gross blood and clots where yellow toilet water should be. I needed to go to the hospital and have CBI, continuous bladder irrigation. Those bags there are 3-liter bags. I had 40 of them, 120,000 cc's of normal saline over 4 days. I had a lot of time to think. One reassuring insight was the strength of the community around me. My urologist was my med school classmate. His wife and I were pediatric residencies together back in the day. The hospitalist was my former medical student, and my evening nurse was a former patient of mine who I took care of when she was a kid. I could have gone to any medical center in Honolulu, but there is something about the connections and support that I felt at my community hospital that helped. I did not feel alone like that rich lady in the ER. I felt a sense of community and that people were rooting for me. Our challenge is, how do we teach that to the next generation of healthcare providers? Where are the role models? How do we guide our patients to teach students about family and community? This is important because I have skin in the game. I turned 65 years old this year. I was inspired to enroll in Medicaid online while in the ambulance bay of an ER waiting for my 88-year-old father-in-law to be admitted for 10% dehydration. And I hope to collect Social Security in 15 months. I have lived an entire 60-year cycle. When I was young, there was a war, abortion was illegal, there was racism, and gun violence had started with 3 assassinations. And today, there is a war, abortion is illegal, there still is racism, and gun violence is still very real. The good news is that, like 60 years ago, change will occur because change is the only constant. These are the trends that I've been following. An increase in the number of elderly needing healthcare, and that's why we're here today. A decrease in the healthcare workforce due to retirement, death, and burnout, not necessarily in that order. And an increase in the amount of healthcare delivered at home versus in hospitals and clinics. And the most recent trend I am seeing is that 85 to 90% of students going into healthcare are female, immigrant, first generation, minority, and young. These are my different classes made up of students who are pre-med, pre-nursing, pre-PA, pre-PT, pre-OT, pre-RT, pre-pharm, pre-dental, health administration, community health, health information management, long-term care, disaster preparedness, and Hawaiian and Indigenous health and healing. This last trend is perpetuated by the not so subtle advertising to caring, compassionate, and impressionable little girls. This is how we make doctors. I write a lot of letters of recommendation for these students who dare to dream and promise to serve. I know that a more nurturing and caring workforce will change medicine for the better. An illustration of the circle of life: when this student told her mom that her professor was Dr. Custodio, her mom said, "Dr. Rick Custodio? Honey, he was your pediatrician." That is happening more and more. Our challenge for our young is to define a purpose beyond the goal of acquiring material possessions and making bank. More away from bureaucratic greed and towards social equity and justice. A purpose that goes beyond the struggle for subsistence and focuses on serving others. A purpose that builds a sense of place, a sense of trust, and a sense of hope for our kupuna. During the pandemic, I felt that purpose and urgency in our younger generations when we got a CARES grant to train community contact tracers. We wanted to make sure that in addition to the clinical science, these contact tracers would be trained to and know how to serve vulnerable populations and how to deal with mental health issues. We had over 3,000 applications for 150 slots. Grades and degrees were important, but the priority was to find candidates who had community heart. The easiest way to describe community heart is to imagine that you're a big family gathering, it's 11 o'clock, and everyone is beginning to go home. Community heart is that one kid that stays back and helps you clean up. Now, as we move forward in addressing the needs of an aging population through health professions education, we need to better understand how a person's development and foundation of family and community impact their health, wellness, healing, and recovery. We also need to actively start encouraging and seeking out pre-health profession candidates who have community heart, purpose, and a desire to serve. This is the future I see, a future where older adults are not alone and are healthy because family and community are integrated into their care. Mahalo, salamat, and season's greetings.
Dr. Rick, thank you so much. That just was perfect following what Peg had to tell us about community and connection. We will move now to our roundtable. So one of the things that we want to talk about is a concept of intrinsic capacity. And some of you may not be familiar with that term, but I'll kind of give some opening comments here. So the concept of intrinsic capacity was identified by the World Health Organization in 2015. It's defined as a combination of a person's mental and physical capacities that can be explained biologically. Let's see, can we share the slide on intrinsic capacity? There we go. Okay, so the graph on the left depicts the self-reported physical functioning of adults over the lifespan, where we see relative stability in younger years of 20 to 40, with decline that ensues in middle age of 40 to 60, and then sharper decline after age 60. Intrinsic capacity includes 5 domains where we see decline associated with aging, including locomotion or mobility, cognition, psychological, vitality, and sensory. So shifting how we think about aging from a disease-oriented medical approach to a that's more reactive to a more person-centered capacity approach, it's good because it encourages prediction, prevention, and person-centered care. But while this approach holds promise towards mitigating functional decline, chronic conditions, and early mortality, the question is, does it also address other factors that contribute to harmonious aging? Harmony refers to balance based on differences instead of uniformity. Harmonious aging aims to recognize the challenges and the opportunities of old age itself, ease the tension between activity and disengagement, heal the integrity of the body and mind, and emphasize the interdependent nature of human beings, such factors as social, family, community, cultural considerations, and spirituality. So today's interprofessional roundtable panel will address the question, is the World Health Organization's intrinsic capacity framework the right model to guide healthcare professionals? We'll begin with our discussants. First of all, Dr. Liza Goldblatt. She's a leading educator in integrative health and interprofessional education. Dr. Catherine Kalasa is Professor Emerita in East Carolina University and an expert in food science and dietetics. Dr. Senthil Rajaskaran is a senior associate dean at Wayne State University with rich experience and leadership in medical education. And then we'll follow up with Brooke Hazen, who is a DNP student from Vanderbilt University, who will address the learner perspective on this. So we'll start off with Dr. Goldblatt.
Hello, everyone. Can you put up the slide, please? Thank you. So I think we all want to retire to Hawaii. Weather is right, the hiking is great, and clearly the healthcare and honoring the elder just sounds like a wonderful example. So in really looking in depth at the IC model, we're calling it capacity IC. I think that while it's an excellent one and one that we want to definitely look at as a model, it does mostly focus on the biological. And Dr. Rick brought forward areas that are really essential for healthy aging. I'm sure we'll all agree with it. And it is interesting to note that this morning we learned about how isolation and depression truly are global. So Hawaii is a unique area, very unique, being significantly influenced by other cultures, including several from East Asia. And the conference planning a committee, when we met together several times, when we looked at the IC model, we all agreed that it ideally would include the importance of family, community, spirit, honoring various cultures, and I would add in honoring the elders. That being said, I don't want to discourage all of us that live here on the mainland, because there are two movements that blend the IC model and the core values that Dr. Rick presented. One is called the Whole Health Movement, and it began at the VA. And our earlier speaker mentioned the importance of asking the elderly or the seniors, what matters to you most? So they started this movement. You can find an excellent definition of it online, and I'll refer to those in a bit. And then there's also the integrative health movement, which really started back very strongly in the 90s. And it consists of conventional medicine academics and what we used to call the CAM, complementary alternative health professions. Now we call ourselves the complementary and integrative health educators, all working together. And complementary and integrative health includes acupuncturists, chiropractors, naturopathic physicians, direct entry midwifery, and licensed massage therapists. These are all licensed health professionals. We also include traditional world medicines, such as Ayurvedic medicine, traditional Chinese medicine, Anami medicine, yoga, and more, all that have approaches to healthy aging, health, and well-being, as well as the treatment of many diseases and conditions, and all of which are well integrated into their medical systems in their respective countries. So these two movements address the body, the biological, and the mind, the emotions, and the spirit, as well as one's environment. In addition, it really is so time that we all understand that we're all interconnected, individuals, all living beings, and the health of our planet. In 2014, the NIH, it's called NCCIH, National Center for Complementary and Integrative Health, and the AARP did a study indicating 30% of the US population now access integrative health and medicine, and over 60% of our seniors do. Current studies now show that this has increased from 36 to 40%, and for our seniors, anywhere from 60% to 88%. When I was president of a traditional Chinese medicine college, we sent our acupuncturists to local hospices for the non-pharmacological treatment of pain, as patients requested acupuncture, not wanting to be heavily sedated. And since 2018, now the US Joint Commission, partially due to the opioid crisis, requires that hospitals discuss the non-pharmacological treatment of pain with their patients. Providence Hospital in Oregon hired our graduates in their geriatric departments for the treatment of pain, for stress reduction, and to teach seniors Qigong in order to improve their balance, increase mobility, and for their overall health and well-being. Qigong is usually, it's like a Tai Chi, it's simplified, is done in small groups, and it thus can somewhat address this most significant issue of isolation and depression that many seniors experience. In addition, now many seniors are doing chair yoga, And that is excellent for mindfulness training and stretching and relaxing. And naturopathic physicians offer natural treatment for pain, excel in both very healthy nutrition and the hard to diagnose cases. Chiropractors and acupuncturists are now formally included in the VA system, as well as mindfulness training for stress. They're excellent definitions, as I mentioned before, of integrative health and the complementary and integrative health disciplines on the WHO website and the NIH and CCIH website. After listening to Dr. Rick and hearing the intrinsic capacity, both of which have such really wonderful impacts on our health and well-being, I'm beginning to sense that we've somewhat lost what I call the heart in our mainstream healthcare system. And that's not because of our health professionals. It's really more the systems that they're in. I believe strongly that our for-profit model is creating this situation because we simply cannot do good medicine and focus on health and well-being in 15 minutes. So we need to change health professional education to bring back compassion, caring, and self-care. And we need to change our healthcare system to offer the needed time, which I heard brought up earlier today, it takes to really focus on these most important areas if we wish to truly address the importance of lifestyle issues, the promotion of health, and the well-being of our aging population. Thank you so much.
Liza, thank you so much for that. In the interest of time, I'm going to go ahead and move on to our next roundtable discussant, Dr. Kathy Kalasa from East Carolina University. We'll let her take the floor.
Thank you. I'm looking at the intrinsic capacity model through the lens of a dietetic professional. In addition to teaching and research, I maintained a clinical practice primarily in the outpatient and community settings, which served all groups, all age groups, which a lot of dietetic professionals do. I do like the IC framework, but I'm concerned that when you review the literature, nutrition is rarely mentioned. One group recently did recommend putting it in the vitality domain. And if you see my graphic there, my colleagues and I believe that food and nutrition really touches all of the 5 original domains that are highlighted in red, and also those other factors that our planning committee added. I did enjoy Dr. Rick's opening comments. While we all can't share all the beautiful flowers of the islands, it seems to me that people everywhere on our globe share food with their family and friends as a way of expressing love and caring. So food is important as we think about, and nutrition, as we think about the intrinsic capacity. Most people really do think about food. I've got 4 quick points. First, frailty and malnutrition are established risk factors for the loss of function. They are recognized in the intrinsic capacity literature. The Academy of Nutrition and Dietetics, along with the American Society for Parenteral and Enteral Nutrition, do have definitions for malnutrition. Typically, and most often in the hospital setting or long-term care setting, the registered dietitian will screen and make recommendation to the physician who actually does the diagnosis of malnutrition. But that only affects a very small percentage of elderly people. For it looks like, or the estimates are somewhere between 3 and 9% of free living patients out in the outpatient setting have malnutrition, 22% in the hospital, and more, about 30% in long-term care. So if we're thinking about keeping function, we need to think about nutrition and maintaining it in older adults. Secondly, the activities of daily living, which include feeding yourself, are discussed in the IC literature, but the instrumental activities of daily living, including things like accessing and preparing your foods, are less frequently mentioned. IADLs really need a greater emphasis in promoting healthy aging. As an example, we're all hearing about food insecurity. It's in the news every day. Health professionals can, in the clinical setting, screen for food insecurity. They can help connect people to the resources that they need. And then the dietitian really can help counsel a patient on how to get quality diet, which is important in retaining function. A third kind of point is that many of the chronic disease conditions that we have a nutrition component. And about 50% of older American adults have obesity. That affects function. And so the standard advice given to young adults for voluntary weight loss may not be effective, and more importantly, not safe for seniors or older people. They actually, if they followed that same kind of advice without paying attention to diet quality and without the right kind of exercise, could actually lose function rather than improve their function or improve their other metabolic areas. So dietitians can conduct nutritional assessments as well as promote adoption of preventive strategies for aging that include evidence-based diet quality that address fragility, frailty, disability, and probably what's most important is what matters most to those patients.
Thank you, Dr. Kalasa. So now we'll hear from Dr. Senthil Rajaskaran for the medical perspective.
Thank you, everyone. The advantage of going last is that all the intelligent things have been spoken. So, Kathy is right that I used to be at Wayne State University School of Medicine, but again, it's a topic is very opportune because I moved to Abu Dhabi in United Arab Emirates to be closer to my parents and my wife's parents in India so that we can address our parental obligations here. And it has been only a few months since we moved here. And what in this very brief session, I'll keep it very short. I just want to reiterate what Kathy mentioned about intrinsic capacity, and then I'll focus more on health professional education and in terms of its lack of presence in addressing these topics. There is tons of evidence to suggest that internationally, not just in the United States, the model of care in the geriatric population is disease-centered, like in any other population. And part of the reason I moved here is to make sure that my father and my wife's parents don't receive just the disease-based care. And whereas we all know that the model of care ideal for geriatric population is the function-based care, and Peggy and Lillian and Nancy just beautifully articulated how the function-based care is important for them, what matters to them is more important. And the functional ability is in turn determined by the intrinsic capacity. And two other factors, which is environment, and also the interaction between the environment and the intrinsic capacity. And so it is nothing but the composite of all the physical, mental capacities of an individual. And already, I don't want to repeat what Kathy mentioned about the components of intrinsic capacity. I'd like to spend a few minutes on what we see in health professional education in terms of lack of our willingness or ability to address these topics. Despite multiple reports and publications, the age-related demographic change is not being matched by a growth in relevant and adequate emphasis in health professional education. And this inadequacy of coverage of this content is not only seen in the knowledge area or skills area, but all three across: knowledge, skills, and attitudes are being inadequately covered across the health professions. And this also is pertinent to all aspects of caring for the elderly population. And so it is absolutely important that the health professional education community takes a huge stride in making an effort, conscious effort, to include significant amount of educational material all the way from introduction to advanced content that will help our learners to be prepared to take care of their elderly population by the time they enter clinical practice. Thank you. So before we move to our learners' perspective, we've got just a minute. So I think we can agree that this new concept of intrinsic capacity is important, and we need to be teaching our students in health professional education. But
out of our three discussants, I wonder if anyone would like to comment on how do we bring these other aspects that, like Dr. Rick talked about, the community, family, culture, love, caring family. How do we approach that with health professional education? Would anyone like to comment on that?
I think.
Well, since I said food is in all of them, I'd like to comment that we can look at unique kind of pairs of professionals that can come together. For example, OT students could pair with dietetic students. OT students being really good at assessing grip strength, for example, or a wide variety of adaptive tools for cooking and for eating. And the dietetic students could work with them on quality of the diet. So they would reinforce that even when they see these patients separately, they would be focusing on something that's important to maintaining function, that is also important to themselves, eating.
Yeah, and Dr. Centil, did you have a comment?
Yeah, I just wanted to take a slightly different approach and say that there are ways in which we need to motivate our learners and meet them where they are. The current generation, I feel, are motivated to make an impact in community. And so creating experiential learning opportunities are quite important. And so having them really roll up their sleeves, get their feet and hands dirty in the community, working with elderly. And you saw the Olin College students all full of smile and confidence as they were working with Peggy. So that creating those opportunities would be really important. And there's a rich opportunity for interprofessional engagement there. And also utilizing other modern methods of teaching and learning, such as gamification. And seeing there are some papers I read in preparation for this meeting, how some institutions have used gamifications to enhance learning and comprehension of these topics. And of course, taking advantage of the simulation to teach concepts related to aging would be really useful. Thank you.
Okay, well, I want to make sure that we get our learner perspective in here. So,
Kathy, could I add in one brief thing?
Yes.
Oh, okay, thank you. So the one thing that I want to mention, since so many seniors access the integrative health and medicine disciplines, which range from physicians to the acupuncturist to the chiropractor, is there's actually very little education that exists in our conventional medical systems about these disciplines, about their philosophy, about their scope of training, and about how they very much focus on what is optimal health at all ages. So I think a significant gap in health professional education within the US, not so much in other countries. And as Centil was saying, one of the reasons he moved is so it wasn't simply disease-based, not that that's not important, is that I think it's time and it's very important to begin including these other disciplines that really do focus on healthy aging and optimal health. And that they are now start to be included as part of the medical team. There's 75 medical colleges now that have integrative health and medicine departments. And so I think that that is as I say, is a significant medical gap, because so many seniors see their physicians and not even necessarily tell them they're also seeing the acupuncturist or the chiropractors. Thank you.
Thank you. Brooke, do you have some learner perspectives for us?
Yes, thank you so much. Thank you to all the speakers that have come before me, and I will definitely echo all of their thoughts in many ways. But as a currently active learner, I'm getting my doctorate of nursing practice at Vanderbilt University, where I received my nurse practitioner degree. And I will say that one thing that I've been reflecting on in my particular time as a student is that there is not as much emphasis on promoting our duty as within the American healthcare system, specifically, of course, our duty to serving others as a way to make our own life care better. So as opposed to seeing ourselves going to work as healthcare providers to do a job, to make a paycheck, to then maybe also maybe their treatment and patient outcomes are improved. But at the end of the day, we see these people as separate from ourselves, as opposed to if we make their life better, if we make their outcomes better, that we in turn make our overall lives better overall. And so teaching that duty within healthcare providers, I think, would also change. It would automatically be a way for healthcare to change radically if people had that mindset shift, as opposed to sometimes thinking of all these ways that we have already we have tried so hard to make healthcare evidence-based. We've tried to make it most effective, cost effective, we've eked out every possible way to improve healthcare. And the final straw is that it's not value-based, as we've seen already. We are not, at the end of the day, doing healthcare for the benefit of others. We're doing it for gain. And then also we're not taking the time to be a patient advocate. I learned this through my own healthcare experiences, taking care of my older adult father, that he moved through the healthcare system as a very literate person, a very health literate person, but still without a patient advocate on his side. Healthcare really was focused on doing its job, get him in, get him treated, get him out, and not necessarily in the best, always the best outcomes. And so having a patient advocate was important for him even. And so if we as healthcare providers think of ourselves as the patient advocates, the person who's saying, okay, I know the time constraint is 15 minutes, and now we're going to, as a whole country, start pushing back on that in a real way, as opposed to just speaking about it and talking about it in an abstract way, but really pushing back and saying, this is truly not working, and we absolutely have to make a change. And we've gone to the table and we've had these conversations countless times. So I've spent a lot of time working with older adults in experiences where I have hours to meet with them. I work with veterans in disability, and they come to me with these issues. And because I can sit and talk with them for such a long period of time, I have been able to pull together so many different things. And I send them home with, here's a book to read on this. Here's 2 or 3 diagnoses you should go and talk to your provider about, because nobody has identified this in you. You may have, a variety of mental health issues that could be addressed, or healthcare treatment plans that could be changed. Nobody's catching it because they just aren't spending the time to see the big picture for the patient. And so anyway, at the end of the day, healthcare providers are up against a wall. We're asked to provide the most effective, the most patient-centered, the most evidence-based, with only tiny little interview times. And we've tried everything. And now the model has to change within schools, within the absolute upper echelon. Intrinsic capacity is a wonderful thing, but at the end of the day, is it enough to overcome our hurdles? It is not.
Well, we've definitely raised the question of how do we bring these other aspects to educating healthcare professionals. And so now I'm excited to hear from 3 respondents to the comments that have been made. So we're going to hear from just a couple of minutes of reflections based on their unique perspectives. First, Dr. Zori Talib will give us her thoughts as a community engaged medical educator. Then we're going to hear from Dr. Kathy Gruss with the perspective from psychology and education. And then third, we're going to hear from Dr. Nancy Kuzmal, who has a strong background in social work, education, and research. So we'll start here with Zori Talib.
Yeah, thank you. It's a pleasure to be here and really wonderful to hear from those who have already spoken. So I'm sort of listening and I'm recognizing sort of the system dynamics that are at play. You know, on the one hand, with an aging demographic, we clearly need cultural shifts in our family dynamics and our value system at a societal level. We clearly need health systems evolution and change to really appropriately meet and preserve health in the current context. And I'm now thinking about, okay, but what does that mean? What does all this mean for health professions education? And for the forum members who were here earlier in the day, we were talking about, well, in the context of shifting societal spaces, policies, et cetera, you know, as health professions educators, we need to figure out, okay, how and what implication is there on the workforce, on the health professions education systems, and what actions do we need to take? So as I'm sort of digesting or thinking about that, I think there are those three levels. There's the space of health professions education, the macro context, the policies, the accreditation systems, seems to me they need to evolve. And it's not a futuristic thing that we can afford to wait until some technology is built. This demographic shift is upon us. We really need to work with our health systems, but also the accreditors. We need some regulatory requirements around pushing us to be better, to be really responsive, so that caring for an aging population isn't a silo activity, but it's truly what we do. So at the macro level, I see really a need for us to evolve quickly. Again, we can't wait for this. And then at the institutional levels, we also need to recognize we are caring for an aging population, and there's so many different ways in which institutions need to be responsive to this. I think even in the way that we are managed and governed, we talk about community engagement in our governance, and even having older individuals as part of our leadership and governance. I mean, I manage a department with a lot of faculty. The aging workforce, the educators are themselves older adults, and we need to be thinking about what that means. We talk about the burnout and the retirement in our health clinicians, but we also have that same thing within the education workforce. So at the institutional level, I think we need to evolve to be responsive. And then, of course, we need to evolve at the learner level, at the education space level, the curricula that we teach, even the educators themselves, you know, moving into the community to be taught. I thought today was fantastic, hearing from our older adults themselves and letting them be our educators. You know, that is sort of the shift that really needs to happen. So I think I feel inspired, but I also feel a sense of urgency that we can't keep waiting and talking. And one of the things we talked about this morning was we need to start like visualizing what does success look like. I think we've identified a lot of pain points in our systems, but what does it look like when we play it out well? And maybe if we put our heads together and really think about what success looks like, we can start taking steps in that direction.
Yeah, that's great. Dr. Gress?
Hi, thank you. It's a pleasure to have this opportunity to share some of my thoughts about our work today. I'd like to start with just a perspective that we've been talking about, and that's the perspective of a health promotion focus rather than a disease forward focus, and the importance of that as part of our health professions education curriculum, that they need to understand that there's a lot of benefit to thinking from that perspective. We often train more on the disease end of things and diagnosis and dealing with people who've reached a level of care. But there's a lot of advantages to be training our learners to thinking about ways to promote health and well-being in our elder population. So that's one thing that I think is very important to help ensure that we mitigate against symptoms from getting worse, and how we can take a health promotions perspective to do that. Specific to psychology, you heard a lot today about loneliness and that being something that we want to combat in our older adults. And from a psychology or mental health perspective, you can see the progression from loneliness then turns into depression. And then unfortunately, we're seeing a problem right now with high rates of suicide in older adults. So really there's an imperative there, I think, to incorporating that type of approach into our training of health health profession students. The other thing to think about is we've mentioned this, but we haven't really put a pin on this, is that we don't have a solid workforce that is really trained to provide high quality, competent care to older adults. And while that's a good aspirational goal, I think there is an imperative there, like you talked about, Zoe, but we're not going to get there overnight. And then there's a real advantage to us to trying to promote well-being and not have things progress such that they require the intensive care that somebody that's a high functioning professional would be able to provide in that capacity. We just don't have the capacity in our workforce to deal with things. So we really need to focus on the health promotion piece of this. The other thing I love about this conversation is that we are really clearly articulating that there's an interdependency at all different domains. And that really speaks to the mission of the forum here, is that each of us has a piece of helping to promote healthy aging in our population. And I think that's so essential to keep that at the forefront. From my disciplinary perspective, oftentimes it's crucial to be working very closely with colleagues from other health professions, because an individual might present with symptoms of depression, and then we need to discern, is this related to a medical condition? Is this perhaps related to early stages of cognitive decline? What's going on there? So it's really, again, an imperative for us to be talking with each other carefully to promote the best health outcomes for our older adults. And then the final piece I'll share with the group that I think is certainly lacking right now in psychology training as a broad piece of health promote education is a focus on community. We're pretty good about focusing on the family, focusing on the individual factors, but I don't think we're doing enough about thinking about the role of communities in promoting health and well-being and supporting our older adults. And that's something I'll take from today's session as a place that need to do a little bit more thinking. So I will stop with that to keep us on time. Thanks.
Thank you so much. And now let's hear from Dr. Kuzmal.
Well, I was brought in to talk about how the intrinsic capacity model connects to social work. And the good news is that the intrinsic capacity model, particularly with the harmonious aging factors, is social work. So social work has taught for generations the person and environment model, which is about the interaction of the individual with their strengths and problems, including physical, mental, cognitive, emotional, spiritual, with their environment. So their social environment, their family, yes, their physical environment. So the Olin College engineering students who worked on those projects to modify physical environment is all part of that. The problem is getting social work students interested in working with older adults. Separate courses don't work because the only people taking those are the students who identify or self-identify an interest in aging. There's a long history of attempts to infuse aging content across the curriculum. There are books developed on it. There was significant investment through the Gerald Rich Project 15 years ago in infusing aging content across the social work curriculum. Social work students say they want to work with families and children, and yet they don't conceptualize that older adults are part of families. And at the same time, social workers are good at, this is the stuff we're good at. Quality medical care is really important, but quality medical care without community policies and practices cannot alone support somebody's ability to age in place. That transportation policy, that walkability, those kinds of factors are, I don't want to say as important, just as important as quality medical care to somebody being able to stay in home and community. You know, Dr. Sleep talks about connecting students to older adults through classroom models, and I think that's what's needed in social work. I've talked to many social work practitioners who work with older adults, and it was often that accidental experience with an older adult that got them interested in that field placement that they really didn't want to have in an aging setting, that they got stuck with and they didn't want to, and they went and they loved it. And so how can we find ways to expose, you know, in my field social work students to older adults, perhaps like the Olin College model with the engineering students, through their education to get them interested in this, because this intrinsic capacity framework and with the social family community factors is good social work.
Thank you. Thank you. So now I wanted to ask all of our speakers, our discussants and respondents to make sure their videos, cameras are on and their mics are open. And we'll ask for some questions. Already in the chat, there was a question about distinguishing between the age-friendly IHI 4M model and intrinsic capacity. So does anyone want to address that at all? Or I can talk about what the 4Ms are if there's someone else that wants to address it.
Pausing to look around. You all help me see if there's any hands raised on Zoom.
Yeah.
I see one over here. Kathy has a comment.
Well, I mentioned the concept that voluntary weight loss among older adults is often discouraged because of concern about making function worse, the development of sarcopenia or something like that. And yet you have older people come and say, I want one of the 4Ms, what matters most?
Yeah.
I want to be able to run around after my grandchildren or my great-grandchildren. I want to get up off the floor. I want to be able to do this. I want to be able to do that. Those things require some weight loss for many of these individuals. And so it can be done safely and it can be done appropriately, but they don't need to be discouraged. They rather need to have the right people supporting and helping them accomplish what they want. And that's where the 4Ms can play in, but it's not automatic.
Yeah. And just FYI, those other M's stand for it's mentation, medication, mobility, and what matters most. Let's see, are there any other hands up? So I wanted to ask.
We have one here, Kathy. Hold on a
Go
second.
ahead. Yeah.
It was a question that came from our patient partners. And this, by the way, over the 10 years I've been in the forum, one of the best parts of the forum is when we talk about the models in which we think about things. And this has been a really good discussion about this. But one of the things that impressed me about both the Southern voice and the Northern voice was a meaningful role. It didn't have anything to do with their physical condition, although they were healthy enough to do it. It was helping people with opening up the milk carton or driving your young ladies around. It's to what extent, are we medicalizing this too much? We know that that's what we do in the United States. And really what we're talking about is giving people meaningful roles, and there's, which is social engagement. It is doing things for other people, not necessarily jobs, but we can be working later. But I was really struck with the examples and what you described. Is that you're being helpful to people, and that's an important thing. I'm just struck by that, by listening to our patients.
Which also came up in the story that just preceded, right?
Yeah,
She was, that was the big thing, was that she could engage with the students and find meaning. Go ahead.
These are wonderful comments. Anyone else want to comment on or chime in on that?
I had something I wanted to say.
Yes, Dr. Rick.
In medicine, we train in silos. Then we're kind of thrown together, expected to work like a well-oiled championship team from day one. This doesn't happen in sports, not in the little leagues, not in high school, not in college or pro. In sports, there's individual skill and coaching for the various positions, but more importantly, there's dedicated training time is spent on a practice field, playing together, gelling as a team. Why doesn't that happen in medicine? You know, I propose that we kind of create a model of kind of healthcare that's a healthcare training practice field. You know? So students entering clinical training can constantly be reminded of the values of professionalism, teamwork, and service to the community. And it really does appear that people out there really picked up on all this. And I talked about a 60-year cycle. Well, 60 years ago, community health centers were created to provide healthcare services directly into the poor and vulnerable communities. What I propose is that we kind of borrow the concept and create clinical training centers where students are given interprofessional health education directly in underserved communities. You know, that way the brainwashing can begin.
Zoe?
Yeah, I'm just reflecting on Warren's comment and two examples actually from work I do in Africa. So I did some work on training the workforce in Uganda, actually a rural workforce for an aging population. And the stories that we were hearing about what it's like to age there is they were about urbanization and the disintegration of the community, that as in historically, when older people were aging in their village and in their community, they were staying purposeful and engaged, and you wouldn't really get lost anywhere. You would just wander over to the next home. And so even dementia was sort of masked and not thought of as a pathology. It was just sort of the behavior of the older individual. And there was something that was cohesive and preserved, like it was working there. And now that there's urbanization and the disintegration of the family unit, or sort of decentralization of geographically of the family unit, suddenly older aging has become difficult and more and has created all sorts of other sort of social dynamics. And on the 2 weeks ago, I was in Kenya, and on the flight back, I was sitting next to an elder Kenyan woman. So we started talking about her family, and she was telling me how her mom grew up in the urban setting in Nairobi. They moved there for them to get educated. But her mother-in-law, who is now close to 90, is still living in the rural village. And she said she's doing so well because she's surrounded by grandkids and she's surrounded by family, and she's constantly busy with a sense of purpose, doing something for somebody. And she said there was a stark difference in how her mother aged and actually, passed away recently, in her 80s. And this other lady, her mother-in-law, is like thriving over 90. It's just an observation that that sense of purpose is quite precious, actually. And I wonder how we should preserve that and bring it into our vantage point, even in the health system.
Those are great comments. We have a comment in the chat from Jennifer that some educators are moving towards training in groups, role playing with a specific scenario and these tools. For surgery, for example, checklist for accuracy and quality control was part of the goal, and then teamwork. We're actually doing that at Vanderbilt School of Nursing. We have a new Master of Nursing program where we'll have interprofessional teams who go into some of our low-income housing communities, and these teams will have a panel of individuals who want the team to work with them, older adults, and they'll follow them for a full year, and then they'll do a handoff to a new interprofessional team on the following year. So that's another good idea that's out there.
And Dr. Maxwell?
Yes.
If I may add, as I mentioned before, I'm also at Vanderbilt with Dr. Maxwell. And so my training in my master's as a nurse practitioner was augmented by a 2-year clinical program that was all interprofessional training. So I was placed on a team with a medical student, a pharmacy student. In some cases, some teams had social work students and divinity students and counseling students from different schools around the Nashville and Middle Tennessee area. And we were placed together for a 2-year clinical rotation, mostly doing things within the same clinic, but we also had older adult aspects where we would go to homes to do full medication reconciliations, to learn what it's like to go and be in home, have to, do the medication reconciliation long form, and also hear stories about, family and everything, and navigate that relationship, that patient provider relationship. So I just wanted to add that in as well.
And I'm curious, Brooke, can you speak to, so how did that have an effect? What effect did that have on you as a learner?
Absolutely. I constantly look back on my training with interprofessional healthcare as the enlightenment moment for me in terms of how I provide care. Really, I can speak volumes about my care through Vanderbilt, my training through Vanderbilt in general as well, but that interprofessional level was just absolutely, it made my mindset and how I see healthcare. So
I can echo what Brooke said, because in the early 90s, the Kellogg Foundation funded these projects of interprofessional care. We had one of them, and we had medical, nursing, social work, and public health students meet for an all-day Wednesday. And that was for like 2 years. And we got the most docs, nurses, social work working in the community health centers, because they were based at a community health center. And they had the right value. They had community heart because they had to learn it.
This conversation is so good. And I see our time, we're 6 minutes over the hour. And we could just keep on talking about this, I know. Does anyone want to make any concluding comments or thoughts before we close our session? Okay, well, let me turn this back over to our coordinators.
Okay. Wow. We're just getting wound up. So I think we'll have a great start tomorrow morning when we continue. I want to thank you, Dr. Maxwell. I want to thank all of our discussants and panel members and speakers and everyone in the room, and both virtually and face to face. You have made this a very rich afternoon, I think. We covered a lot. We absolutely covered a lot. So we will start tomorrow morning at 9 o'clock, pick up. So all those great thoughts that you're having, and they're going to percolate all night. I'm sure you'll wake up at 2 o'clock in the morning like I will with a great idea. Like, roll over, write it down, go back to sleep, and bring it into the room tomorrow morning. And we'll talk about supply and demand, which we touched on a little bit today. And on behalf of myself and
Donna Ferguson,
we are grateful, and I'm grateful for such a great co-chair. So we'll see you tomorrow.
Bye, everyone.
Bye, everybody.
Bye.